Focus in on some sports injuries that are common in winter sports in the backcountry, and we're going to use that as a tool or an example to examine different techniques that we can use for splinting injuries that we might encounter both in these winter sports as well as other summer sports, the more complex traumas that can be associated with other mechanisms of injury. As a bit of an overview, I'm going to spend about 15 minutes talking about some of the epidemiology of winter sports, the types of injuries that you should expect to encounter out there. We'll spend 15 minutes talking about some of the basic principles that you need to know when applying any splint. And then we'll spend about 60 minutes practicing these techniques. So my goal for this is to be as hands-on as possible. We're going to focus in on the knee, wrist, ankle, and shoulder. Our focus today is going to be on isolated musculoskeletal injuries, but keep in mind that these same principles can be applied to other more complex traumas as well. So the patient that I want you to keep in mind as I'm talking is pretty much me, right? The guy bombs past you on the ski hill, is busting through the moguls, catches an edge, wipes out, rolls 50 feet, and comes up grabbing his knee. Everything else is fine, but there's clearly something wrong with that right knee that you need to address. But with that said, this could also be applied to the person who fell off the side of a cliff and tumbled 50 feet through rocks. You get there, they're not mentating properly, there's problems with their breathing, they're maybe bleeding out quite a lot. You obviously need to address those other things first, but you can use these same principles to splint a broken arm in that patient as in a patient who's got an isolated injury from a sports injury. To talk about the epidemiology of winter sports, we need to define what sports we're talking about. There's quite a few of them out there. Ski jor is one of my favorites. Based on these two pictures, can anybody guess, do I ski or do I snowboard? A Google image search for gaper snowboarder was surprisingly low yield. That was the best that I could come up with. But we're going to focus primarily on skiing and snowboarding today. And I did throw in an image of Jeremy Jones just to prove that snowboarders can be cool too. We're going to focus on skiing and snowboarding because that's what most other people have focused on as well. If you look into the literature, you'll find that most of the research has been done on skiing and snowboarding injuries, and I think that's appropriate for several reasons. First is that these are very popular winter sports that a lot of people are engaging in, and they have a high injury potential. So if you think about the types of injuries that are likely to happen over the course of the winter, a lot of them are going to be associated with these two sports. And secondly, skiing and snowboarding are moving increasingly into the backcountry, with backcountry skiing becoming more popular, splitboarding technology getting better and better every year. I think this is something, these are the types of injuries that you may be called upon to be responsible for potentially even several days during a prolonged evacuation if your buddy busts a knee in the middle of a 3-day-long ski tour. As opposed to, say, sledding, which actually has quite a lot of injuries as well, and a surprising number of studies reporting on those injuries. Backcountry sledding hasn't really picked up, so it's going to be a lot easier. You just load them into the car at the bottom of the sledding hill, drive them to the hospital, and get them to definitive medical care. And again, I want to reemphasize that we're going to focus on these sports, but these principles apply to many different types of injuries. Whenever you look at the literature, you got to examine how the studies were done, and let that guide how you interpret the studies. Most of the studies that have been published sample patients at mountainside clinics, at emergency departments, or at inpatient units in hospitals that were near ski and snowboard resorts. Because of that, they've examined a relatively sick or seriously injured portion of the population of skiers and snowboarders that hurt themselves. Again, you think to me, right? I take that tumble, I bust my knee. If I'm able to get down to the bottom, pop a few ibuprofen, drive home and sleep it off, that's probably what I'm going to try and do, right? Whereas if you look at the folks that end up in the ER or admitted to a hospital, it's likely because they hurt themselves pretty seriously. And those types of injuries are rare, and also not likely what you're going to be as likely to deal with. At that point, you'd be more thinking about what's the quickest way to evacuate this patient to definitive medical care. So for that reason, we'll look at two studies from mountainside clinics, because I think they best approximate the patient population that we're interested in, which is patients that are hurt enough to require medical attention, but are well enough that you may be able to provide the medical care they need without evacuating them in critical condition. The first study I'd like to look at was published in the American Journal of Sports Medicine and looked at the top injuries in skiers and snowboarders. What I want to draw your eye to in this table is that for snowboarders, we see a lot of upper extremity injuries, especially in the wrist and in the shoulder. And notably, ankle injuries are also quite common. Can anybody think of why that might be? Locked in, soft boots. That's what it all comes down to. Skiers don't tend to hurt their ankles because their boots are effectively a rigid splint that keeps their ankles from moving around. Snowboarders have a little bit more play in the ankle, and that play can lead to more injuries. Moving on to some of the injuries that this study reported in skiers, we see it all comes down to the knee, right? There's 110 different ways to mess up your knees, and skiers have found most of them. Why do we see these knee injuries more commonly in skiers than in snowboarders? Yeah, because it's split up, right? Those knees are working independently. They're not able to support each other. And if you think of how a person stands in a snowboard, there's not a lot of potential for rotational knee motion, whereas opposed to a ski, you've got like a 4-foot-long lever that moves your knee in any different direction. It's kind of an absurd sport, and it's a recipe for disaster, which is what we see when we look at the types of injuries we see in skiers. Another thing I'd like to point out is the metacarpophalangeal ulnar collateral ligament, or MCPUCL for short, injury that we see in skiers a lot. That ligament is a ligament that keeps your thumb from moving too far away from your fingers in the plane of your fingers. The reason we see this injury commonly in skiers is because they're holding on to poles. Their thumb is more isolated from the rest of their fingers than snowboarders. So when they fall, they've got a higher potential for catching their thumb in the snow and then exerting a strong force on it. So that's a very common injury to see in skiers as well. And then the final thing that I'd like to point out with this table and the previous table is that there is a lot of crossover here, right? We do still see knee injuries in snowboarders, and we still see shoulder injuries in skiers, but the relative prevalence is quite different. Let's look at a similar study that was run out of Big Sky, Montana, that looked at the common injuries in skiers and snowboards. And we see it's relatively the same thing. A lot of knee injuries in skiers, a lot of shoulder and wrist injuries in snowboarders. So this study was also interesting because it looked at how patterns of injury change as skiers and riders become more advanced. I don't want to delve into this too deeply, but I think it's important to keep in mind that when we look at these studies, we're often not grasping the full picture. So while it's fair to say that snowboarders are more likely to injure their wrist and shoulder because they typically have like a fall on an outstretched arm as they're falling, we actually find that that's more true for beginning snowboarders who are falling a lot. I tried snowboarding one day. It was the most painful day of my life because you do take a lot of those falls, and you do catch a lot of them with your arm in a very non-safe way. But as you look at more advanced snowboarders and skiers, you tend to see those differences decrease because they're less likely to injure themselves, but if they do injure themselves, it's more likely to be a very intense injury because they're not sliding out as commonly, but when they do slide out, they're doing it at 40, 50, 60 miles per hour, and then the injuries become more and more resistant to trauma, and not really what we're trying to focus on for this presentation. So in summary, the most common locations for injury for skiers are going to be knees, thumbs, and shoulders, and for snowboarders, the wrists, shoulders, and ankles. And most of these injuries are going to be soft tissue injuries. Sprains, strains of the muscle or tendon, potentially rotator cuff injuries in the shoulder. But we do see some fractures, especially in the wrist, clavicle, and ankle. And so, unsurprisingly, we see those more commonly in snowboarders because those are areas that are more commonly injured in snowboarders. And also makes sense if you think about the types of force that would be put on a wrist or on a clavicle in a snowboarding fall as compared to the type of force that's put on a knee as a skier twists their knee with their ski. You just think of what's going to break first. For the knee, it's a lot more likely to be the ligament, whereas you've got a better potential for causing a fracture when you think of the way that the snowboard responds. So let's shift gears for a minute and focus on some basic principles of splinting that we could apply across all different types of splints. The first applies to backcountry splinting, and that's that you're going to have limited assessment abilities to determine exactly what type of injury your patient has suffered from. To definitively diagnose a sprain versus a strain versus a fracture very frequently requires advanced imaging techniques that you're just not going to have in the field. The good news is that you typically treat these injuries the same regardless. Certainly once they get to definitive medical care, the treatment is very different for a sprain versus a fracture. But for you in the field, your job is to immobilize and evacuate. And you're going to immobilize and evacuate in largely the same way, regardless of whether it's a sprain or a strain, or a bruise, or what have you. Immobilization has several benefits, not the least of which is that it minimizes pain for the patient. Obviously, it's going to hurt a lot for them to move that injured extremity, so by creating a rigid support that keeps it from moving, you're going to really save them a lot of pain, and that can be very important for your evacuation, especially if it's going to take a while to get them to definitive medical care. You may or may not have adequate analgesia that you can give to your patient, so keeping them from hurting is going to be a very important thing for you to do. And furthermore, it minimizes further tissue damage and blood loss. That's pretty easy to imagine for fractures, I think, where we can think of those sharp bone ends sliding around inside somebody's wrist or arm. I think that that's probably not going to be a good thing, right? We want to keep those bone ends from moving around and causing further tissue damage. I think this is also true for many ligamentous injuries. It's a little bit harder to visualize, but I think of a metaphor as of a rope, for example. If you can think of a rope, it doesn't typically break in half and snap right down the middle. You'll start to see some fraying. Some of the strands of the rope will break, while some of them will remain solid. And the same is what we often see in many types of ligamentous injuries. So what we want to do is protect those strands that haven't broken yet, and that will enable the other strands to heal more quickly. This is maybe not something that's going to make a big difference in the 48 hours it takes to get the patient to the hospital, but could really help their healing in the long term. There are, of course, downsides to choosing to apply a splint or immobilize an extremity, one of which is that it takes time to perform and might not be appropriate in all environments. We've got to think of our scene safety first, right? Obviously, you can move your patient to a slightly safer environment, but if you're towards the end of the day, it's maybe 3 o'clock, you've got another hour of sunlight, it's -10 with wind chill, and it's 2 hours to the car, that's a time where you might really consider whether it's worth it to you to take the time to stop and splint this patient, or if it's more important for you to think about the environment and just get to definitive medical care as quickly as possible. And furthermore, whenever possible, you would like to take a walking evacuation. I don't know if anyone's ever, who here has practiced carrying somebody out of anything? How much did it suck? Scale of 1 to 10?
11.
11, that's right. So if you can get your patient to walk out, you'd like them to walk out. That's obviously very difficult if they've got a splint that's extending 3 feet or 3 inches below their foot. Or maybe they're going over uneven terrain and you've got their arm plastered up against their chest. They might not be very comfortable with that. So do think there are always downsides. And the bottom line is that the decision of how to splint and whether to evacuate is always going to be a judgment call. And actually, it's not my goal in this presentation to give you the judgment to make that call correctly. I think that's way outside the scope of what we could do in a 2-day wilderness medicine conference. What my hope is to give you guys some tools to put in your toolbox so that if you do make the judgment call that a splint is needed, you'll feel like you're able to do that even if you don't have the materials that you're used to encountering in a hospital. And finally, I just would point out that, you know, as much as we talk about downsides to immobilization, I think it's fair to say that for most musculoskeletal injuries, in most cases, splints are beneficial for your patient both short and long term. So let's talk about some of the steps we would take when splinting an extremity. The first thing to do is going to be to thoroughly assess the injury. And this really feeds back into what Miles was talking about in our patient assessment. We want to go through all of the other steps of the patient assessment, obviously, right? It's splinting a wrist fracture is definitely secondary to making sure your patient's airway stays taken so that they're not bleeding out on them. But once you've gone through the rest of the steps, you're down to your secondary assessment in your patient assessment. You really want to expose the injury all the way to skin, take a good look at it, feel it, see if there's swelling, see if it's tender to your palpation, get a sense of how much strength the patient has. Can they push away against your arm with their leg, or are they completely unable to use it? And as well as get a sense of the range of motion, both how much are they able to move the extremity, and how much can you move the extremity with them relaxed. And this is important both because it's going to help you determine what type of splint is necessary, and also because it's important to establish a baseline for your patient so you can continue to monitor them throughout the evacuation and report that to definitive medical care when you deliver to the hospital. The next important thing to do is to assess the distal neurovascular status. So this is essentially checking to make sure that there is still blood getting passed to the site of the injury and that the nerves have also not been compromised at the location of the injury. This is really important because when we think of the outcomes for an injury such as a sprain or a strain, you obviously want to get your patient to definitive medical care, but somebody can have a torn ACL for several days as you're evacuating them. Potentially could even have, if it was a stable fracture, for days or hours as you evacuate them to definitive medical care. But if they're not getting any blood whatsoever to their hand, that's an emergency that you need to address much more quickly and should affect your management of the patient. How we typically assess distal neurovascular status, we ideally will take a pulse. So in the injured extremity, take a pulse, touch your patient's hand or grab a finger, ask them to tell you which finger you're grabbing, so you can tell if they can feel in that extremity, and then ask them to either wiggle their fingers, squeeze your fingers. Some people will have the patient pull up their toes, push down with their toes. I'm not going to get into that too much. I think it's something that a lot of people have been exposed to. It's something I want to have you guys practice later on. And if it's not something you're comfortable with doing, please ask the people you're working with or the facilitators that will be rotating through. I think this is much easier to explain how to do well and more of a one-on-one type teaching. Whenever possible, you want to splint the injury in the position of function. Position of function is another concept that's kind of hard to define that we're going to hone in a little bit more in our small group sessions. And one way to think of it would be the position that's most comfortable for the patient. Obviously, if I think a great example to start with is if you look at the picture of the leg, it's going to be very uncomfortable for a patient to have their leg all the way straight, splinted out. And it's important to pad behind the knee to add a slight bend in the knee, and that makes things much more comfortable for your patient and can improve their outcomes in the long term. For the arm, you can see in the middle picture, there's typically put some bend in the arm, support some of the weight, and keep it up against the patient's chest. And the wrist, it's important to have a slight dorsiflex bend in the wrist. You don't want to have the wrist entirely straight or bent down towards their forearm if you can avoid it. Fingers typically have a slight curl. Again, kind of working with the patient, seeing what's most comfortable with them. This is something that I would like you to work with your facilitators in their small groups and with your simulated patients and have them play what feels comfortable, what feels a little more. However, it's not always possible to split in the position of function. And if you have a patient who's got very limited mobility, like to get to position of function would require you to force a joint in a way that joint doesn't want to move anymore. Or if there is an obviously angulated fracture, so like a angle in the bone where there's not supposed to be an angle, you typically don't want to mess with that. You're going to split that injury as you find it and try and get it to definitive medical care as quickly as possible. The one exception to that is if, when you're doing your neurovascular assessment, you find that distal to the injury, you're not able to find any pulse, your patient doesn't have sensation or isn't able to move their extremity. That's a sign that potentially the injury has already compromised the patient's neurovascular status, and now your risk benefit of trying to reduce that angulation just changed a little bit. Because if it's going to take you 12 hours to get to the medical care, it might be worth it to take the risk of reducing that angulation because it might make a difference as well if you can save that patient's. When you're applying a splint, it's always important to immobilize above and below the injury. So if we think of, for example, the radius and ulna, we not only have to immobilize this part of the arm, we also have to immobilize the elbow and the wrist. I think that makes a lot of sense if you think about the anatomy, right? If you're moving your wrist around, or if you're using your elbow around, that's attached to your radius and ulna, so it's going to move those bones as well. So if you're thinking of a long bone injury, a good way to think about it is you splint the bones and you splint the joint above and below the bones. If you're splinting a joint injury, you're going to splint the joint, you'll split the bones below and above as well. It's very important to pad the splint, both for your patient's comfort and to prevent tissue damage. If you've got an awkward part of the splint that's pressing in on your patient's skin, that can cause pressure sores, especially over an extended evacuation. So make sure that the splint is well padded and comfortable, and periodically reassess the distal neurovascular status, both to make sure that the splint that you've put on has not compromised things further, and also to make sure to keep appraised of your patient's condition as it's changing one way or the other. Are there any questions on this up to here? I should have mentioned earlier, feel free to interrupt me if you do have questions on it. Let's talk a little bit about some of the supplies that you might use to splint. And here I'm going to focus primarily on supplies that I anticipate might be available to you during your backcountry recreation. We saw some sick stuff that the helicopter crews bring with them earlier today. I don't typically throw that stuff in my bag when I'm going out for daily skiing. And there's a lot of really cool ways to splint, vacuum splints, and so on that have a great application in more of the rescue world, but haven't really made it into the recreation world as much. And for this presentation and for our practice, we're going to focus more on the recreation world and hopefully give you the tools that you might use to be able to splint your training. Supplies in that case are often going to be limited. You probably won't have exactly what you would want. And you may have to improvise a little bit with what you've got to be able to make a splint that's going to function in your patient. Splints can be either hard or soft. So examples of hard splints might be a SAM splint, a vacuum splint, sticks, ski poles, Abipro, something like that that's going to provide a very rigid support to the affected injury. Or they can be soft, something like bundled clothes, a sling and a swap, or a packed sleeping bag to provide support, something along those lines. The important thing is that you support the injury and work to immobilize it. It doesn't necessarily need to be a rigid splint to be an effective splint. The goal is to, like I said, to support and immobilize it, and to keep in mind what your goals are for your patient. Are you going to have them in a litter and you're carrying them out? Is your goal that they're going to walk out? Is your goal that they're going to finish their skiing day and then go going through years afterwards? There's really a lot of variables at play when you're deciding what type of splint to make. I do want to point out that SAM splints come packaged and typically, like in your pack, will sit in a very flat arrangement. But you do need to put a curve in the splint, as is kind of demonstrated here, in order to provide a rigidity. So for example, this splint is mostly flat. It's a little bit chewed up, so it's not 100% flat. But you can see that I can move it quite easily like this. But if I put a C curve into the splint, it now has quite a bit more rigidity where that curve is going to apply. So today our supplies are limited, which is great because it'll encourage you to improvise as you're practicing. Feel free to use any of the supplies that are up on this table. My two asks are, one, to not apply a piece of tape directly to the same splint padding, just because it makes the splints more difficult to reuse in future trainings. And two, if you can, remember which side of this line you pull your supplies from, and when you return them, put them back on the same side of the line. Some of these supplies were brought by Miles, some were brought by me. We'd like to keep them separate as much as possible. So I want to look back at epidemiology real quick before I cut you guys loose with some practice. Just to point out that if we exclude wounds and concussions from the picture, we can treat almost all of the most common skiing and snowboarding injuries just by being able to splint the knee, wrist, ankle, and shoulder. So the skills that you are going to learn today are going to cover a lot of the very most common things that you might experience in the country on a skiing or snowboarding trip. So how the next hour is going to work. We're going to split up into groups of 2 or 3. You'll grab some splinting materials. Ideally, if you have some materials in your first aid kit, you would use those. I think it's good to practice with the materials that you typically have with yourself in the backcountry. And then either inside or outside, for 15 minutes, each group will, of 2 to 3, will practice building some of these splints. We might not have time for everybody to build each splint. 15 minutes, it should be enough time to build maybe 1 or 2, depending. But you'll practice building those splints. I won't tell you exactly how to do it. My hope is that you start the process of learning to improvise. I'll have, as you can see here, a few suggestions or examples of what a splint might look like. You can use that as a jumping off point. But it's not my goal to say that this is how a splint for the knee must be built. More, I want you to think about what would I need, what's my outcome for a splint for the knee. I want to immobilize an injury, I want to support it, I want to be sure that I'm not compromising neurovascular status. I need to splint both above and below the injury. Keep that in mind, build your own splint, and we'll have facilitators circling throughout the groups to provide feedback, give you some pro tips, and answer any questions you might have. But it's my goal that you get your hands on and are practicing as soon as possible, rather than waiting for people to show you how it's done. I think oftentimes, like I said, it does come down to improvisation in the backcountry. So if you only learn to do it one way, you're SOL if you don't have what you need to do it that one way. So learn to improvise, that's the most important skill you'll come away with today. So with that said, we're going to start with knee injuries. Like I said earlier, knee injuries are typically ligamentous. and are going to require a lot of support. One, because it's a large joint, so there's a lot of muscle and a lot of bone that you're going to have to support. And two, because it's going to be weight bearing if you're hoping that your patient's going to be able to self-evacuate. And it's important to consider that evacuation method when you're constructing your splint, because some splints are more amenable to it than others, right? If we look at this image here, there's no way this person's walking out. But if we look at either of these two options for splints, there's a good potential that that person might be able to assist in their evacuation or walk themselves back to the car. Also, I feel it's really important for knee injuries to get as much weight out of your patient's pack, or simply take the pack off of their back and give them ski poles or trekking poles for support and balance as they're walking. That will likely do as much to protect their knee from further injury as any splint that you can build. So that's an important thing to keep in mind. Talked about knees a little bit already. Talking about shoulders, common injury for snowboarders. And guys, this will take like 3 minutes or so, so don't worry too much about getting too comfortable. Shoulder injury is very common for snowboarders. 2 types of injuries you might keep in mind. Soft tissue injuries to the shoulder, like torn rotator cuffs, damages to those muscles that are going to be best supported with something like a sling and a swath, something to take some of the weight off of that injury and to keep the arm in tight against the chest and not flopping around a lot loose. It's really difficult to find an image that effectively explains what a sling and a swath should look like, so I'm going to leave that to your facilitators to show you some different ways to do that. I also put this image of safety pins on the slide to remind me that I think one of the most elegant ways to do a sling and a swath in the wilderness is if you carry a couple of safety pins in your first aid kit, you can safety pin your patient's base layer to their shoulder, and that provides the sling that'll take some of the weight off of their injury, and then you can help them into their jacket with that safety pin still in place. If my jacket's zipped up, then this essentially provides a swath, keeps my arm from coming out away from my chest. So you essentially, with 1 safety pin in 2 minutes, did something you would have needed 2 triangle bandages in 5 minutes for. So that's a really good technique to keep in mind. I always keep a few safety pins in my first aid kit. Yeah, another great way to do it would be to bring the bottom of the shirt up, and that'll also provide kind of this part of the sling and swath to help support the shoulder. In shoulder dislocation injuries, we're not going to talk at all about how to reduce or when to reduce. That's kind of outside the scope of today. But if you choose not to reduce a patient's shoulder dislocation or don't know how to, it can be very uncomfortable for them to have their arm hanging against their side as they're walking out. So you want to find a way to kind of prop it up into this position. You can use a Sam split, fold it into a triangle for that, or this is a great application for like a sleeping bag in a stuff sack or a few wadded up parkas to have them rest their arm on. So I want everybody to get a practice doing a sling and a swath of some form, and I want everybody to practice supporting a dislocated shoulder. Ankle injuries, there's a couple of different ways to splint. What I really wanted to touch on here is that you typically have to choose between a splint or the patient's boot. Rarely, if ever, if you're able to get a splint on and fit them in their boot, it means that they need to go get their boots resized. Probably they hurt themselves because they were skiing sloppy because their boots were too big. So you have to choose which you're going to do, and that has a huge implication on your evacuation decision, especially if you're thinking of like a backcountry skiing trip where if they don't fit in their boot, they don't get in their ski, they can't ski out. They need to be either towed behind you or airlifted out or something. So keep that in mind. If possible, boots often provide pretty good ankle support and can be a viable alternative to a splint. And finally, for wrist injuries, I'd like everybody to practice immobilizing the wrist. And you get bonus points if you can immobilize the thumb with your wrist splint. Typically, how I've seen that done is just to provide something for the patient to kind of hold onto or have a curl at the end of the splint, and then wrap their thumb around that as you're finishing your splint. And in this way, you could also immobilize that MCP-UCL sprain that we often see in ski.